in the previous class, we have already seen about the radius anatomy, which includes the introduction portion where we have told about its location and their two ends. And then we come to the parts of radius. So already we have seen about the proximal end, shaft and distal end and their parts. And also we have seen about the muscle attachments in the flexor as well as in the extensor. In this session, we will be continuing with the muscle attachments. Blood supply, radial artery. So the blood supply comes mainly from the radial artery, which runs parallel to the bone, and there is also an anterior as well as a posterior interosseous arteries which are feeding the shaft. The veins drain via the radial and interosseous veins into the brachial veins. Then for the innervation, so there is no direct innervation. The bone itself isn't directly innervated, but the periosteum, the outer covering, gets sensation from the musculocutaneous nerve anteriorly, while the radial nerve posteriorly. Surrounding the muscles are innervated by radial and median nerves. And then we are going to see about the site determination. So how do you tell the left from the right radius? So the proximal end is a disc-shaped head. The distal end is wider with styloid process on the lateral, that is on the thumb side. The shaft has an interosseous border, faces medially toward the ulna. So here is the pro point or pro tip. Hold it with a styloid toward your thumb and it fit naturally. Next, we are just dealing with the clinical aspects of fracture. So clinically, radius fractures are common. The distal ones often from falling on outstretched hand. It is also called as Colles fracture. And also we have dorsal fracture. It is also called as dorsal displacement. And then we also have Smith's fracture, which is volar displacement. Here the Colles fracture is like dinner fork deformity, and the radial head fractures from the elbow trauma. It also has symptoms which includes like pain, swelling, deformity, and which is important for OT techs in surgery prepare. Then we are just dealing with the summary or radius or a recap. So radius, to wrap up the radius, it's a key bone for wrist and elbow function. The parts include head, neck, tuberosity, shaft and distal end. The muscles like biceps, flexors, supinator for extensors, the blood from the radial arteries, innervation via periosteum nerves. Clinically, watch for the fractures like Colles in surgery. So this is the summary of this session, and now let's switch to its partner, ulnar. So before that, we have a riddle challenge. I am a forearm bone. On the thumb side, I roam in fractures and I know. What am I? Of course, it's radius. So we are also giving a quick quiz. Name the distal end feature of the radius. So it is of course styloid process. Why is the radius critical in the wrist surgeries? So the answer is it forms the wrist joint alignment, vital for motility. And also we have given a discussion topic, how does the radius anatomy affect the wrist surgeries outcomes. So here is the instructions, group discussion, fixation methods, example plates and share insights. So this session is referred from Manipal, Manual of Anatomy, Rosen Wilson, Anatomy and Physiology. Also from B.D. Chaurasia, Human Anatomy, Volume 1, 2, as well as 3. Thank you. So we had already dealt with radius. In the previous session, we have seen about the parts of radius, which includes upper end, distal end, proximal end, as well as shaft. And also we have seen their parts as well as muscle attachments. Also, we have from this session we have seen about the blood supply, innervation, and also about site determination and the clinical aspects, that is fractures, mainly Colles fracture. And also we have I have given a summary or a recap. So in the next class we will switch to its partner, the ulna.